Thank you, Chairpersons. I'd like to thank Anazil, thanks Dr. Duseja and Charles for inviting me here for this talk. In the next few minutes, I'll be talking on prediction and prevention of organ failures in acute decompensation of liver cirrhosis. So in the last decade or so, our understanding of decompensation has changed. And we know that in compensated cirrhosis, there are two types of decompensations. One is acute and the other is a non-acute decompensation. And this is a study which was published recently, large number, 617 patients from 2 Italian centers. And they looked at outcomes in both these cohorts. And if you can see the outcomes in acute decompensation are significantly worse as compared to those in non-acute decompensation. So this is what we are interested in, and this is what I will talk of in the next few minutes on how to prevent organ failure or ACLF in patients with acute decompensation. So what is acute decompensation? So this is defined as any first or recurrent grade 2 or 3 ascites within less than 2 weeks, first or recurrent acute hepatic encephalopathy in patients with previous normal consciousness, or acute GI bleeding and any type of acute bacterial infections. So now in the last few years there have been some concepts of different phenotypes of acute decompensation, and I'll talk of this in a little more detail in the later slide. So you have stable decompensation, you have unstable decompensation, then you have a pre-ACLF stage, and you have a ACLF stage. So the idea is to identify or predict factors which would prevent this pre-ACLF or ACLF stage where you develop organ failure. So these are the patterns of decompensation and progression to organ failure. So you have compensated cirrhosis, which leads to decompensation, and like I said, you can have acute decompensation or non-acute decompensation. So since we're talking of acute decompensation here, basically organ failure or ACLF is a subtype of acute decompensation, and if untreated, they lead to either a liver transplant or death. So decompensation of cirrhosis occurs through two distinct pathways. Like I said, a non-acute and acute one, which includes the organ failure pathway. And non-acute decompensation is the most frequent pathway of the first decompensation, and acute usually represents further decompensation. So this is the spectrum of acute decompensation. So you have stable decompensated cirrhosis, you have unstable decompensation, you have pre-ACLF and ACLF. So organ failure or ACLF is the extreme spectrum of acute decompensation. Now, how does acute decompensation present? So it presents as ACLF in about 16% cases, pre-ACLF in about 17%, UDC in about 22%, characterized by persistent unstable inflammatory status resulting in further acute decompensation events within 1 year, and about 50% have stable decompensated cirrhosis. So why do we need to prevent organ failure in acute decompensation? So if you look at this, this is again from the Canonic study, acute decompensation versus those with organ failure or ACLF. The survival is significantly poorer in patients who develop organ failure as compared to those with simple acute decompensation. So that's why we need to prevent organ failure or predict organ failure in these patients. So what are the factors predicting organ failure in acute decompensation? So early identification and initiation of adequate treatment for precipitating events remains a cornerstone in the treatment of acute decompensation to prevent progression to organ failure and ACLF. So you need to identify what are the precipitating factors which convert acute decompensation to ACLF or those with organ failure. Now this is one of the first studies which gave us the concept of ACLF, published in Gastroenterology in 2013, and they looked at patients who went on to develop ACLF, and these are all patients who had acute decompensation. So patients who developed ACLF were younger, were more frequently alcoholic, had more bacterial infections, and higher number of leukocytes and higher CRP. And if you look at the major precipitating events which led to ACLF in these are bacterial infections, active alcoholism in the past 3 months or suspected alcoholic hepatitis, GI bleed, and neurotoxic drugs. So the first three formed bulk of precipitating factors which lead to organ failure or ACLF in patients with AD or acute decompensation. Subsequently, the same group came out with a score which predicted organ failure in patients with acute decompensation. So this was the CLIF-C AD score. And again, the derivations set included almost 1,000 patients from the canonic study. And this validated a new scoring system using simple clinical variables that can be updated to determine the mortality of patients who present with acute decompensation but have no ACLF. And this study also showed that this score actually performed better than the existing MELD score, MELD sodium score, and the child score. So what are the parameters which were used in this score? There was the age, serum creatinine, sodium, WBCB count, and INR. And if you look at this side, in the derivation set and the external validation set, the CLIF-C AD score did better than MELD score, the MELD sodium score, and the child-Buick score. And again, this table shows the same thing, that the 90-day mortality, 180-day mortality, and the 1-year mortality was better predicted by the CLIF-C AD score as compared to the MELD score and MELD sodium and the child score. So what this score suggested was that once a patient of cirrhotic patient is admitted with acute decompensation, you assess the CLIF-C organ failure score for diagnosis of ACLF. If ACLF is absent, then you look at the CLIF-C AD score, and the high risk, if the CLIF-C AD score is more than 60, then that's a high risk patient. 3-month mortality is more than 30%. If it's a low risk, less than 45, then the 3-month mortality is very low, less than 2%. So this is the group you need to look out for and prevent and treat them aggressively to prevent them from going into acute or chronic liver failure. Now, when initially I talked of the various phenotypes of acute decompensation. So this is a study published in 2020 in Journal of Hepatology, which came out with this concept of 3 clinical courses of acute decompensation of cirrhosis. So patients with AD without ACLF develop 3 different clinical courses. So the 3 groups significantly differ significantly regarding the grade and course of systemic inflammation. So there is high grade at enrollment with aggravation during follow-up in pre-ACLF, low grade at enrollment with subsequent steady course in UDC, and low grade at enrollment with subsequent improvement in stable decompensated cirrhosis. So prevalence of surrogates of portal hypertension throughout the study were high in the unstable decompensated cirrhosis versus they were low in the low in pre-ACLF and stable decompensated cirrhosis. Of course, this study has fallacies. I saw Shalimar sitting here. I think he's written a letter to the editor. Maybe we can discuss that during the discussion. So portal hypertension, only surrogate markers were used, and it was also questioned whether TLC and CRP are really reliable in patients with liver cirrhosis and hypersplenism. So again, the same study, acute decompensation without ACLF is a heterogeneous condition, and the pre-ACLF group obviously had a much higher incidence of infections, ACLF, and death. and there was significantly higher mortality, as you can see in the pre-ACLF group as compared to the other groups. Now, the same study identifies precipitating factors and precipitating events associated with clinical course of acute decompensation of cirrhosis. So again, about 1,273 patients, non-electively hospitalized patients with acute decompensation. This study identified precipitants that are significantly associated with a distinct clinical course and prognosis in patients with acute decompensation, so that specific preventive and therapeutic strategies could be instituted in these patients and improve outcomes in patients with decompensated cirrhosis. And what this study found was that the type of precipitant was not as important as the number of precipitants was. And there are certain criteria for being actually called a precipitant. So a precipitant is one which affects the course of liver or can cause decompensation, and it has to coincide or precede with the worsening of acute decompensation or organ failure. So again, in this study, the precipitating events were similar to what we saw almost 10 years ago in the canonic study. There were again bacterial infections, alcohol-related liver injury, GI bleed, drug-induced brain injury. So these constituted the major precipitating events. The others were paracentesis without albumin, tips, DILI, etc. And again, like I said, the number of precipitants is important to decide which patient is going to go into organ failure. So proven bacterial infections, severe alcoholic hepatitis, GI bleed with shock and toxic encephalopathy fulfilled the diagnostic criteria of precipitants in this study. And so this study demonstrated these 4 major precipitants which led to organ failure in acute decompensation. This is again a study which validated external validation of the PREDICT study, which was published in liver transplantation. Another model, which is the Padua 2.0 model for predicting organ failure in acute decompensation. So basically they've used pre-sepsin, which is a plasmatic biomarker that reflects toll-like receptor activity, and combined it with the Cliff AD score, the child score, and so if you have a score of less than, a Cliff AD score of less than 50, a PSP of more than 674, this improved the identification of patients at risk for ACLF. So basically what they've tried to do is add a biomarker to the existing clinical models. A lot of work is going on biomarkers, and this is again a paper from Trebeka et al., which have done a lot of work on acute decompensation, published in Frontiers in Immunology. And this is a heat map showing the median levels of systemic inflammatory markers at enrollment. And you can see that the markers were significantly higher in patients who went on to develop ACLF as compared to those who did not. Another study published recently, again looking at predictors of organ failure in nosocomial ACLF, and they found that the MELD score, hemoglobin, and leukocytosis were important. And again, the number of risk factors was important in predicting patients who went on to develop ACLF. So we looked at how to predict ACLF, what are the precipitants, and how do you prevent. So well, obviously you have to look at you have to identify the acute decompensation. You have to see if there is any reversal of the etiology of cirrhosis. I'm not going to talk of details of supportive treatment, assessing fluid status, nutrition, etc. Most importantly, I think you have to identify and treat the precipitating factor, which is bacterial infections, GI bleed, and alcohol. And like many other studies showed, you need to correct anemia, hyponatremia, renal dysfunction, and coagulopathy, and of course avoid hepatotoxic drugs. So prevention is basically what we really do in day-to-day clinical practice, is identifying the precipitants and trying to decrease them or treat them. So this is my last slide, a take-home message, a slightly busy slide. So the recently recognized patterns of decompensation are non-acute decompensation and acute decompensation. AD has 4 distinct phenotypes: stable, unstable, pre-ACLF and ACLF, with ACLF being the extreme end of the spectrum. Acute decompensation with organ failure has a worse prognosis, so that's why you need to recognize the patients who are going on or probably will go on to develop organ failure. Systemic inflammation and portal hypertension are the key to which decide the progression of acute decompensation to patients with ACLF. It is important to identify precipitating events and predict organ failure in AD to prevent progression. Bacterial infections, alcohol, GI bleed, and toxic encephalopathy are the most important precipitants globally, and they've been shown in studies as early as 2013 and as late as 2022. MELD score, anemia, and leukocytosis have also been identified as factors leading to organ failure. The CLIF-C-AD score identifies patients of acute decompensation, and I think that's a very easy clinical score to really use in clinical practice. Biomarkers may have a role, but I think at present they're not being really used in clinical practice. I think basically what it boils down to systemic inflammation and preventing sepsis is the mainstay of preventing organ failure. So early identification and initiation of adequate treatment of precipitating events remains the cornerstone in treatment of acute decompensation to prevent progression to organ failure and ACLF. Thank you.